video to cover the economics of healthcare. So we're going to discuss improving health of people in the United States, different healthcare around the world, information problems and externalities in the market for healthcare, and the debate over healthcare policy in the United States. So healthcare expenditure in the United States is higher than any other place in the world. Why do you think that is? What are some potential ideas? One potential idea is the quality of healthcare. Another is the system of payment for healthcare. So we have a different system of payment than other places. So how do we rank this? And a third potential reason, supply and demand. So there's a higher demand for healthcare here. So in this chapter, we'll address some of the elements of healthcare that make it a rich field of study for economists. And there's lots of disagreements in economists when it comes to healthcare. So first, we're going to look at trends over time in the U.S. The last couple centuries have brought incredible advances in healthcare outcomes for Americans. So in 1850, the average life expectancy at birth was 38 years. In 2011, it was 78.4 years. So when you read the chapter, we talk about some of the reasons for this. Obviously, advances in medical sanitation, food access, refrigeration of food, all of these things contribute to this. The average height of adult males was 5'7" in 1850. And the taller, they believe, the healthier and stronger you are to fight off disease. And it's really related to access to food and nutrition. The infant mortality rate went from 228.9 per thousand live births to 6.1 in 2011 for Americans. Some explanations, again, improved nutrition, and then the public health movement. So in the late 19th century, earliest 20th century, they really identified that spread of disease and unsanitary conditions led to all of these deaths. So they talked about sanitation in the workplace, sanitation with food distribution, and all of these things which have contributed to the life expectancy growing from 38 to 78 years. The most dramatic gains in health occurred in the 20th century. So if you look here, starting in 1900, there was a dip in 1918, but it was due to a flu epidemic. And then it's been pretty much on rise since the 1950s. Now the death rate, correspondingly, has gone down. And again, there was a spike with the flu epidemic. So why is the death rate falling? Well, one of the main reasons the death rate is falling is medical preventions and treatments are reducing the death rate. Another reason is the death rate falls. So we're going to talk about a couple different diseases. So certain diseases or all causes, the in general death rate has gone down, right? The blue line. But some diseases have gone up. Cancer has been fairly flatline. Cardiovascular disease, on the other hand, the more we know about the causes and the treatments that we can provide, the death rate has gone down. However, liver disease gone down a little bit, but kidney disease and diabetes have increased. The deaths from kidney disease and diabetes. One might say that increased access to food and nutrition has an adverse effect because now people overeat or eat unhealthy foods because the access to food is completely different, and therefore they have obesity and kidney problems. So are rising incomes causing better health? Well, incomes certainly have risen. Health economists suggest that better health causes better incomes, not the other direction. So they don't believe that better incomes cause better health. They believe that better health leads to better income. Incomes rose substantially through the 19th century, but heights, a popular measure of health, fell during that same time period. The causality between economic well-being and health. So the causal relationship between economic well-being and health are not completely settled. So Increases in national income allow for higher expenditures on research and development, including medical research. And this is one of the big debates on whether or not we should have a market-based healthcare system, which is, we have like a hybrid here in the United States, or a universal type healthcare system like the UK. But the problem is that if there's no incentive, economic incentive to be more efficient, to have more advancements, to further research and development, if there's no economic incentive, then why would we do it? And this is the reason it stifles medical research. Um, so medical research is a fruitful area for future research. So we're going to talk about the comparison with the United States. Most healthcare services in the United States are provided by private firms. So payment to those firms generally comes through health insurance. This is what we call a third-party payer system. A third-party payer system is when the actual user in the transaction doesn't directly pay all of the cost to the provider. So the medical professions, doctors, hospitals, things like that, are providing the service. The patient is the one consuming the service, but the third-party payer is a health insurance. And health insurance is a contract in which the buyer agrees to make payments or premiums in exchange for the provider agreeing to pay some or all of the buyer's medical expense. And as you know, you have to read through that very long document that says this is included, this is excluded, this has a copay, this applies to your deductible, this doesn't apply to your deductible. But according to the stats from 2009, employer-provided insurance represents 49% of all people with insurance. So 49% of all people have insurance through their employer-provided insurance. And 5% have individual insurance. I believe updated numbers in 2014 that employer-provided insurance went up to 55% with the mandate. The majority of Americans have private insurance, and then about 29% have government-provided insurance. So that could be Medicare or Medicaid, the VA, or other public insurance systems. So Medicare, of course, is if you are over the age of 65 or over. Medicaid is income-based. The VA, of course, is for veterans. And there are other income disability-based, like Mass Health. So the Medicaid is usually provided through the states in certain, and they have their own version of it. So we have Mass Health. And then approximately 1 in 6 Americans, or 17%, have no health insurance. This is the real reason there was a big push for the Affordable Care Act, which we'll talk about. So insurance payments can take the form of fee-for-service, where the doctors are reimbursed directly for their services performed, or a health maintenance organization known as an HMO, where the doctors receive a flat per-patient fee. Now, remember I think it was chapter 1, but people respond to economic incentives, right? And so HMOs, like, you receive a per-patient flat fee, so you don't charge separately for the services you provide. One might question, is it just about churning out as many patients as possible and not specifically listening to health concerns? I don't know. I don't know the answer, but one might say that, where a fee-for-service might have a different incentive, but you might also be incentivized in the fee-for-service to bump up tests because it's in your benefit. We'll talk about the principal agent problem shortly. So why are so many Americans uninsured? Compared with the rest of the world, the United States has a high proportion of its population uninsured. So one reason is some people can't afford insurance. Can afford insurance, but elect to go uninsured and pay for their expenses as they incur. Let's just say the average person pays $4,000 or $5,000 for premiums. If you're sick and all you have to do is pay if you need to go to the doctor, so you can go to Doctor's Express for $150, why are you going to pay $4,000? But then it's kind of a catch-22. What happens when they have a real accident and they're uninsured? What happens then? Who's paying for that? And others cannot afford health insurance. So one of the big parts of the Affordable Care Act was the pre-existing condition. Now, Massachusetts is a unique situation because First of all, Massachusetts had a rule that you couldn't exclude for pre-existing conditions prior to this federal mandate, and they also were one of the first states to mandate health insurance before the federal mandate anyway. So there wasn't a big change in Massachusetts compared to other places with this new situation. All right, when people who cannot afford health insurance, when they need health care, they generally either go without or use reduced price or free services. So they go to a free clinic, or they don't go for preventative care, or any of these things. So the federal government's legislated and acted in 2012 was motivated partly as a desire to reduce the number of uninsured Americans. So when we're comparing healthcare systems around the world, Canada has what we call a single-payer healthcare system. Healthcare is provided by private firms, but paid for by the government indirectly via taxes. So in Canada, the citizens don't pay directly, they pay indirectly via taxes that are then used to fund private firms. Individuals pay nothing for out-of-pocket services. In Japan, they have universal health insurance. Every resident is required to enroll in a nonprofit health insurance society or in the government's national program. But they also have, most of the hospitals in Japan, I believe, are private. Individuals have substantial copays on this, though. So they're pushing back and putting some of the burden on the individual. It's not paid for all by taxes, but it's required that you enroll in one of the programs. The UK has what we call socialized medicine, where the government pays for and provides the health insurance with negligible copays. So they might have a $5 copay or something in that realm. But basically, and the difference here is in the UK, the government provides the health insurance. So the hospitals and the doctor's offices are all paid by the government in the UK, which is different than Canada and Japan. One of the big differences in the UK, though, is that since the government decides, they also rank the order of who's going to get insurances. So in the chapter, it talks about who's going to get services. So it talks about how hip replacement surgery or breast reconstruction surgery after a mastectomy was placed at the very bottom of the list because they consider that elective and a non-emergency situation. So the wait times for something like that are significantly more as compared to the United States, where you could get that in a few weeks. So, healthcare spending per person. In the United States, the income per person, if you look there, is about $45,000, $47,000, but the spending is over $8,000. So we are off the line, an anomaly on this line that seems to be pretty in line with the spending per person. But does that relate to the additional cost because of behaviors? Does that relate to the fact that we demand more services because we have a market-based system, so that we're outspending because the opportunity is there and we have a third-party payer system? Healthcare is a normal good. The higher income leads to higher expenditures. Remember, we talk about in supply and demand a normal and an inferior good. So a normal good, the more money we have, the more we might be willing to spend on healthcare. And the other scenario is the more money you have available, you might push for more tests. You might question this. You might have more elective things. You might spend more, on things that are covered outside of the insurance or other things like that. So it's a normal good. But the United States spends a greater portion of income per person than any other country, right? So comparing data across countries, it appears the United States is getting a bad deal. Now, there are many reasons. So in the chapter, we'll talk about how people measure things are a potential reason for skewed results. So life expectancy in the United States is 78.2. In all other countries that we ranked against, Canada, Japan, United Kingdom, and OECD average. So the male life expectancy after 65 is lower in the United States. The female is lower in the United States, not by a significant amount, but lower. And infant mortality rates are much higher in the United States. I might also ask the question, do we try to save much infants at a much earlier stage. So we have infants that are born, right, at one pound in the NICU. So does this skew our results? And healthcare, of course, we know that obesity is a problem. And 27, this is a self-reported, but 27% and 57 hospital admissions per year are based on diabetes. So potentially it's just our lifestyle differences that are causing our poor life expectancy rates, right? So some problems with comparing data across country. First of all, countries may not collect data in the same way, so this skews results. Problems with measuring healthcare. Quality of healthcare is hard to measure. So I have more access to potentially more prescription drugs, more also medical. One would argue a lot of times that we in the United States are funding all of the medical research or a significant portion of medical research because there's economic incentive here, and then everyone else benefits once once the research and development has become mainstream. So the other countries don't have to spend as much because we're doing all the trials, we're doing research and development, we're doing drug trials. So we're spending all the money to potentially come up with that next greatest thing, and other people benefit around the world once it does happen. And quality of care is hard to measure. Lifestyle choices plays a role in this. So obesity and diabetes may have more to do with the choices of consumers than effectiveness of healthcare. Maybe our healthcare system is effective, and our lifestyle choices, we do riskier things, or we have a more obese population. So problems with determining consumer preferences. There's a disconnect between prices people pay and services received. I had a conversation with someone the other day, and the more you pay for things, so if our employer pays and we have a small copay, there's no incentive to shop that around. But if you have a high deductible plan and you're going to have to pay the first $2,000 or $4,000 on a family plan, you might ask, well, is there another location that I could get an MRI, or is there another medicine that would do the same that costs less? Because it's coming out of your pocket. So the healthcare market is characterized by what we call asymmetric information. It's a situation in which one party to an economic transaction has more information than another. This can lead to market failure or the inability of the market to maximize the economic well-being. So there's two main forms of asymmetric information. First, it's an adverse selection. One party elects to take part in the market or not based on private information. Let's just go back to, if I have a choice to be uninsured and I know I'm very healthy, I weigh the risk reward of being insured, the cost benefit analysis, and I'm like, I'll roll the dice, I'll take my chances, right? Do you buy an umbrella policy? Well, I'll roll the dice, I'll take my chances. So I have information to know how healthy or unhealthy I potentially am. Now, if I know that I have some condition or I'm frequently sick, right, then I'm more likely to sign up for insurance. So by nature, adverse selection happens to the insurance company. People who are higher risk want to sign up for the insurance in the first place, right? And then there's the moral hazard. So adverse selection happens at the time of the transaction. Moral hazard happens after the transaction. So let's just say I get a life insurance policy and I get like the best tier one, right? And I'm like, woohoo! Now I'm insured and my family will collect money, so I'm gonna go out and go skydiving today, or I'm gonna go do this, or it's behavior that one party chooses different actions. It's like now my employer is paying for all my health insurance. I'm gonna go smoke a pack a day. Now I don't think, even though I didn't smoke before that, I don't think that people necessarily always make that, but it is part of the equation. So one party chooses different actions knowing that the other party will bear some of the cost. Let's talk about adverse selection in the market for quote-unquote lemons. So let's use car examples. Suppose you're looking to buy a used car. If someone offers to sell you a used car, what would you believe the car is high quality and the seller just happens to want to sell it to you? Probably not. Or the car is low quality or a lemon and they're trying to sell you to unload their problems. If it was so great, why are they not holding on to it, right? If you offer a moderate price, then only people with low quality cars will sell to you. In the example, they say you're willing to pay $10,000 for a great used car, or $5,000 for what would be considered a lemon. So you offer $7,500. But somebody who has a high quality car that they think is worth $10,000 won't sell to you. But somebody that has information that you don't know about, they're willing to sell you the lemon for $7,500, right? So without further information, you don't want to buy a car from anyone that's willing to sell you a car. I don't want to buy a car. I don't want to belong to any club that will accept people like me as a member, said Groucho Marx, right? So health insurance suffers from similar adverse selection problems. The people who want health insurance are the ones who are likely to use it. So the premiums need to be high to cover the expected costs. So insurance really works with risk pooling. So you need a bunch of healthy people to pool with the unhealthy people in order to offset the risk for the insurance company, or the premiums need to be higher. But now people with only moderate needs may find health insurance too expensive, and they might start dropping out. This becomes the adverse selection death spiral. It's happening, or has been happening, in the Affordable Care Act, and we'll kind of talk about that. The problem is lessened if people are very risk averse or wanting to avoid risk. I think about people who are really first people to kind of sign up for different types of insurance beyond health insurance, and those people are usually doctors, accountants, and things like that. I'm sure being able to pay for it counts, but also risk adverse people that so I don't want to I know the cost of potential health insurance problems. Like, how much would it be if I needed open heart surgery and I don't have insurance, right? So I would want to insure against that. So for health insurance companies to cope with adverse selection, they have tried to lessen the impact by excluding pre-existing conditions. It's a normative value-based judgment question whether the gains for society through avoiding adverse selection outweigh the cost to society through reductions in health insurance coverage. So if the health insurance companies argue that if they have to cover all these pre-existing conditions, then the premiums for everyone go up, and then maybe people can't afford insurance, and then all kinds of people become uninsured, so which is better for society? An alternative way around adverse selection is to mandate individuals to carry insurance. So that's what we've tried to do with the Affordable Care Act. What they're trying to do is get more healthy people to sign up for health insurance and risk pool to pay for the unhealthy people. Let me ask you, do you feel it's fair? If you focus on being healthy and doing all the healthy things by eating correctly and working out and making sure that you're healthy, should you have to pay for someone who makes what you would consider unhealthy choices in life? Examples: most states require automobile and accident insurance. So the 2010 Patient Protection and Affordable Care Act both introduced the individual mandate to buy health insurance and the restricted exclusion of the pre-existing conditions. So moral hazard in the health insurance market. The moral hazard refers to the actions people take after entering into the contract that make the other party worse off. People with car insurance might drive less carefully, knowing they are financially protected if they crash. One example is like you get a rental car and you know that this car isn't yours, and you bought the insurance, and you beat on the rental car and you drive it completely different than you would drive your regular car, right? People might use health care when they don't have to pay for the full cost, going to the doctor unnecessarily. Now, I don't know if everyone wants to do this. I try to avoid going to the doctor, time-wise and all of those things. So, but maybe people do go to the doctor unnecessarily if they don't have to pay for it. Or just in general, engaging in risky behavior, or accepting excessive treatment options. Such actions would increase the cost of healthcare to society, perhaps without providing substantial benefits. The financial structure of an insurance contract makes the doctors change their behavior also. Ordering unnecessary tests and procedures. Since patients likely pay little out of pocket for additional care, they're likely to agree to the extra treatment. So if it costs me something and you're offering me this extra treatment, sure, why not, right? But if it costs me $2,000, I might say, well, is that absolutely necessary? Do I need that? This illustrates the principal agent problem. The insurance company must delegate decision-making power to the doctor, who may not have the same interests as the company. Some doctors say that this is not why they're overprescribing and that they're really potentially over testing or for malpractice issues, right? Out of genuine concern for their patients. Like, also, they do call it a practice, so I may not know the answer. It could be multiple things. Maybe you do need an MRI or a second MRI because we couldn't see the clear picture, right? Are they doing it because they're trying to jack up the price of this? Or are they doing it because I'm complaining and there's pain? Or defensive medicine to avoid malpractice suits. The key to dealing with moral hazard is try to make sure people don't change their behavior too much. Patients. So one of the first ways is a deductible. So the patient pays the first X of treatment. I have a deductible. Trust me, it makes me question, do I really need to go to the doctor? Co-insurance. This is when the insurance company pays 80%, I pay 20% of the treatment. For the doctors, they standardize payments for a particular illness. So let's just say I have diabetes, you can't charge me more than XYZ for this illness. Such methods reduce but do not eliminate moral hazard problems. So other market failures in the healthcare system. Let's talk about externalities. Recall that an external cost or benefit will result in market failure because from society's perspective, the wrong quantity will be consumed. So a positive externality. So vaccinations reduce the chance of others getting sick around you. So if I get a vaccination, it had a positive effect because other people won't get that as well. Or a healthy population is good for employers, fewer sick days. Negative externalities are poor health choices like obesity, smoking, are paid for by others, like higher premiums and taxes. Should the government run the healthcare system? You guys are going to do a live debate about this, but or in general about the healthcare situation. But they passed, if for public good, there would be strong argument for the government involvement. Is healthcare non-rival in consumption and non-excludable? Neither of these. Healthcare seems to be a private good. Non-excludable means if you don't pay for it, you can't get it, right? So it's one of these weird things. But non-rival in consumption means that everyone can get it at the same time. Well, if there's one doctor performing surgery, can everyone get that surgery at the same time? No. So, however, the externalities and information asymmetries may be enough to generate enough market failure to prompt government involvement, which it has. Overall, the government's role in healthcare is very controversial. So framing the healthcare debate, expenditures on healthcare as a percentage of the national income has been on the rise. So healthcare as a percentage of GDP, so it was a little over 5% in the 1970s, and it's all the way, it has gone to, it's projected to be 19.5% of total income or GDP for the country by 2020. Spending on healthcare per person. All these countries and then the United States is way up here. Growth in healthcare spending is faster in the United States than any other high-income country. But as the costs have risen, the out-of-pocket share of spending for the consumer is smaller and smaller. So it used to be that 40-something% was out-of-pocket spending in the 70s. Now in 2010, it's significantly smaller. So why are the costs rising so much? Is it paperwork? Is it malpractice lawsuits? Is it uninsured patients? While paperwork is significant, it's not increasing fast enough to explain the rise. Significant costs are the Congressional Budget Office says 1%. Economists estimate as much as 7% of total healthcare costs are related to malpractice lawsuits. But again, not rising fast enough to explain the changes. Uninsured patients, an increase the cost between 1 and 4% due to getting treatment in wrong places, like going to the emergency room that should have been something for the doctors. Still not rising enough to explain the changes. Is it the aging population? So this is the so we know that the population is aging due to reduced. They're saying that the effect of excess cost growth, but costs are growing much faster than aging population can explain. Um, they say that service sector cost disease. Service providers, like healthcare providers, have not seen huge productivity gains like manufacturing. Um, so manufacturing, you always hear like focus on lean, and they get huge productivity gains in manufacturing. But in order to keep workers, wages have risen in the service sector also. In an ordinary market, we would expect demand to keep these cost increases in check. But again, there's a lot of interference in the supply and demand of this. But insurance creates a distorted economic incentive, effectively making consumers insensitive to price changes. So if we're not sensitive to price changes, this can lead to the cost disease. It's still not obvious why these effects seem to be worse in the United States than other countries. Maybe it's a combination of all of these things. The American system of private insurance has created significant inequalities in access to healthcare. While healthcare for the rich is probably the best in the world, the same is not true for the poor. Extending healthcare coverage to be more universal has been attempted and rejected several times. Harry Truman proposed national health insurance in 1945. Bill Clinton proposed a universal public-private plan in 1993. Each time, Congress declined to enact the plans. In 2009, Barack Obama proposed significant health changes in the PPACA, the Affordable Care Act. In March 2010, Congress approved this. Scheduled to be fully implemented by 2019, it included an individual mandate, so we are mandated to buy health insurance, state health exchanges, we'll talk about this, to increase access to policies, employer mandate for most firms to provide health insurance, regulation of health insurance, altering how health insurance companies can act, and the expansion of Medicaid eligibility and Medicare cost controls, increased taxes on high-income individuals and insurance plans. The PPACA, the Affordable Care Act, is expected to increase health coverage to over 30 million additional people. They estimate that these increases in federal spending will be more or less offset by an increase in taxation. We now know that that is not true. Many economists have disputed these estimates, of course, and debates remain whether this is the right approach for America and whether we should emulate other Western countries, more government control, or adopt a more market-based reforms trying to reduce the cost by making healthcare markets more like normal markets for goods and services, because the supply and demand doesn't really work at the current situation. So how much does an MRI cost? So in a well-functioning market, competitive forces would keep prices similar. Consumers would shop around and find lower prices and force higher price firms to lower their prices. One of the highest priced ones is $1,900 and the lowest is $2,100. So it's a $6,900 difference. I think medical, sometimes people don't know their doctor referred them, so they don't even shop that, they just go to wherever their doctor referred them, right? So this also plays a role in whether or not you negotiate the price, right? So in conclusion, with healthcare expenditures projected to consume almost 20% of national income by 2020, we must find ways to reduce costs. Whether or not the politicians will find a way to do so is an open question. And we are talking right now about the potential repeal and replacement, or repeal and who knows what, of the Affordable Care Act. So it's a huge debate. Adverse selection and provision and payment do not go hand in hand. The government can pay for health care without providing it, as it is in Canada. So this is an overview, and we will talk about the live debate, and it'll be posted in Moodle.